Hello class, so we're moving on to skin disorders and the integumentary system. So let's see if we can change the page. Here we go. So just a little quick review. There are two major layers of the skin, the epidermis, which is avascular, and the dermis, which houses a lot of the components of the skin. And then beneath these two layers is the subcutaneous, which is the hypodermis, and is closely associated with the integumentary system, but it's not actually part of the integumentary system. So just a little review on the epidermis. There's 5 layers: the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basal. The basal layer is the one that divides rapidly, and then it actually goes out into the the cells actually slough off. One of the major proteins of the skin is keratin. This is a tough, fibrous protein that accumulates in the skin cells, and it waterproofs the skin and protects the underlying layers. Skin cells also have the skin tissue also has cells called melanocytes, and they produce melanin, and this helps to protect the DNA by acting as an umbrella sort of kind of molecule that covers the DNA. And it's a skin pigment, so the light hits it and it can't go through, just like if you had an umbrella. And this depends on genes and the environment. When we lack not melatonin, but we lack melanin, we can have a form of what's called antibioticism. And this is where there is no, the genes to make the melanin aren't there. Then we have vitiligo. This is where there are small areas of hypopigmentation, very low pigmentation. Some people call these sunspots. And then a melasma is where there is a darker patch. This is something maybe like a birthmark, where there's a darker patch of skin. Then we have our connective tissue of the dermis. The dermis' primary connective tissue is in the matrix, which is the fibroblasts making this connective tissue, and then we have a lot of these sensory organs and the sensory cells in this dermis. It contains the connective tissue, and the dermis is elastic, and it has elastic and collagen fibers. These are proteins. The elastic provides a lot of flexibility, and the collagen is going to provide the strength. The dermis does contain the nerves and blood vessels, and they're going to be where the sensory receptors are for the various different things like pressure, pain, touch, heat, hot, and cold. There are some components of the skin that we find in the dermis, and a lot of them go out into the epidermis, such as hair follicles, sebaceous glands, and sweat glands. The hair follicles produce hair, and they are invaginations of the epidermis that go deep in the dermis, and each hair follicle produces a hair shaft that will come out of the dermis, and they're surrounded by hair follicle receptors, so if something touches that hair, you'll feel it. And they also have a muscle called the erector pili muscle that is associated with the hair follicle, so when we get goosebumps, it pulls the erector pili muscles are stimulated, and we houses the hair stand on end. This is when we're frightened or cold. Then we have our sebaceous glands, which produce sebum, and the production increases at puberty. And these are the glands that actually gets affected with acne, and so we see that's why it sort of comes on at puberty. Then we have our sweat glands, which are all over the body. There's 2 major types. There's the ones that do temperature, which are the eccrine sweat glands. They're all over, head to toe. And then we have what I call the sex sweat glands, the apocrine. These develop at puberty, and they're in the axillary region, the scalp, face, and external genitalia. The layer beneath the dermis is called the hypodermis, hypo below. It has a lot of connective tissues, and this is the fatty layer. There are some immune system cells there, and they have large blood vessels and nerves. Here's a nice image, and you can see different components such as the sensory receptors, sebaceous glands, hair follicle, the arteries. There's no blood vessels in the epidermis. The functions of the skin: it acts as the first line of defense. If you go back to inflammation chapter, you can learn about the first line of defense. It prevents excess fluid loss. It actually seals in the water because, remember, the keratin is waterproof. It controls body temperature through the sweat glands and is active in the touch sense, as with the sensory receptors. And then lastly, one of the things it does is it synthesizes vitamin D. So we need to go outside each day and get a few minutes of sun. Depending on your skin pigment, how much you have, the darker it is, the more sun you need each day. The lighter it is, the less sun you need. The skin has a normal resident flora, and it differs depending on the area of the body. This normal flora is bacteria that actually is good bacteria. Most of the time it protects the body. And it's all over the body. It can get in the fingernails, hair follicles, and glands. And most of the time it causes no problems. But when there is an opportunity, like maybe a skin break or inflammatory lesions, these normal microbes can cause infection and allow harmful pathogens to come in, like maybe with a burn or something like that. It could cause the normal resident flora to infect the body. The infection, when it's the skin, can spread systemically from the body if it gets into the blood and into the deeper tissues. A skin lesion is a damaged area of the skin, and the physical appearance of the skin lesion helps with the diagnosis. Some skin lesions are caused by systemic infections and disorders like liver disease or chickenpox. Others are caused by things like allergies or even localized factors such as exposure to poisons like toxins like poison ivy. Skin lesions, is important to note the location, how long the lesion's been present, and how's it changing over time. This is very important if we're looking at cancerous lesions or potentially cancerous lesions. We need to evaluate the color, the elevation, the texture, and the type of exudate or fluid that's being produced and draining. And also if there's pain or itching, which is pruritus. Pruritus is itching. So here's a few common types. It'd be nice to really know each one of them. The first one is a macule, which is a flat, circumcised, it makes a circle lesion. The next is a nodule, which is a raised, firm, and it goes deep. Next we have a papule, which is a solid, small, elevated lesion. A pustule, which is going to have raised, and it's also often has a head, and it has the pussy exudate. A vesicle or a blister is a thin-walled, raised fluid-filled sac, so it has a serious exudate. A plaque is a slightly elevated flat, and it has scale. It's a scale-like lesion. Ulcer is where we have a cavity where the tissue has been eroded. A fissure is a crack in the tissue, and you can see there's a few other ones. Erosion, shallow and moist cavity in the epidermis. The ulcers are usually a little bit deeper, and it can be weeping or bleeding. And a comedone is where we have a mass of sebum, keratin, and debris blocking the opening of a hair follicle. Pruritus is the itching. It's often associated with chemical reactions or allergic responses, and even some infestations like parasites like scabies. The mechanism is not often understood, but it often relies on can be responsive of the histamine being released, and especially with certain hypersensitivities. It can result from the breaking of the skin or even be caused by scratching. Diagnostic tests for skin lesions include culture and staining of specimens, bacterial infections, and microscopic direct observations. So we can look at them under the microscope. We can take a culture, we can grow it. There's also specific procedures for fungal or parasitic infections for diagnosis. And we can do a biopsy, and we can actually remove lesions. And also blood tests, or using we can do skin testing of different allergens. So moving forward into some of the different types of disorders. Let's see if we can show. And so we're going to jump a little bit back and forth between the pictures and our chart. So the inflammatory disorders. The first one is contact dermatitis, which is a type 4 hypersensitivity. If you want to go back to the immune system chapter, this occurs, it's actually delayed sensitivity, so it usually happens after the fact. This is a pruritic itchy rash that develops on the side of contact. It's often caused by irritant or allergen, so it's really the allergen portion, like poison ivy or latex allergies. Contact dermatitis, it has very defined lines, and we can use topical glucocorticoids to treat, which is a steroid cream. And you can see here, you can see this is the tape, probably for my IV. Okay, the next up is Eutecaria. Eutecaria is that itching rash here, or hives. Eutecaria is a type 1 hypersensitivity caused by allergen, usually by ingested food or drugs, and so it's going to be throughout a lot of the body because it came through our blood, and it causes hives, which are hard raised erythematous lesions, which means they're pink or red lesions scattered over the body. Since it's type 1, it's highly pruritic, highly itchy, and it may even can affect the biggest danger, which is the respiratory pathway and the airway, and obstruct breathing. So if somebody has that allergic reaction, it's very important to provide an antihistamine like Benadryl as soon as possible if they're not allergic to that either. Okay, then we have atopic dermatitis, which is eczema. This is a familial disease. You can see it often happens on the joints, like the knees and the wrist. So it's called atopic dermatitis, but a common name for it is eczema. We have pruritic lesions, itchy, moist, red vesicles covered with a crust. It's often symmetrical, so if we see it on one side of the body, we see it the same place on the other. The cause is usually familial hypersensitivity that we see in families. So it's passed on. It's often associated with asthma and hay fever, so it's like a trinity. You see eczema, asthma, and hay fever, allergies, and one of the biggest problems with it is potential secondary infections due to scratching. So the scratching can lead to open sores, and then we can have infections from other opportunistic organisms. For treatment, you can give antihistamines for the itching and moisturizing the skin, and also steroids, glucocorticoids. Next up is psoriasis. This is a chronic inflammatory disorder which is associated with a cell proliferation. So the cells are dividing too rapidly, and they're forming these silvery plaques, often with a red base. Let's see if we can see a picture. So we can see here is the red base, and then on top you see the scale plaque on top. So the cells are dividing very rapidly, forming these plaques. It's chronic inflammatory. Like I said, chronic means it's over a long period of time. Glucocorticoids and tar perforations can be used to treat this. So steroids and tar. Pemphisis is the next one. This is going to, let's see for the picture. We can see here where they have these large lesions, and the skin's raised up. This is an autoimmune disorder where the immune system disrupts the antibodies disrupt the cohesion between the cells in the epidermis. So instead of being held together, they're separated, and it causes the epidermis to separate from the basal layer. And this is going to cause those raised vesicles and things like that. It's an autoimmune disorder, so we want to depress the immune system through systemic glucocorticoids. And this is going to depress the immune system and hopefully provide some treatment. And then the next one is scleroderma, which is where we have huge deposits of collagen in the skin and tissues, where we make too much collagen. And the collagen goes where it's not supposed to, which leads to inflammation. And then the inflammation is going to end up causing us to have scar tissue and fibrosis. And so we end up with hard, shiny, tight skin, and we have a lot less movement of the skin because the collagen is going to kind of turn it into almost like scar tissue. And it can really affect circulation because the obstructions of that scar tissue. We can see, let's see, here we go. Again, like I said, the collagen is deposited. We can see it can cause renal failure, intestinal obstruction, because it actually stops the tissue flow. You see how tight around the lips are and the fingers, you can see there's a lot of fibrosis, scar tissue. Next up, we have our skin infections. So let's go down. First one is cellulitis. This is a deep infection of the dermis and subcutaneous, usually coming secondary to some other injuries. So a bump or a puncture wound or furuncle or ulcer, which is a boil, okay, or ulcer. They're usually in lower extremities with those that have restricted circulation, such as diabetics or those that have poor circulation. And it becomes red and swollen, and often has a streak that runs down the lymphatic vessels. So this is where, you know, if you have a cut or a wound, you keep an eye on it to see if the redness and its pain goes up or down from that wound, open wound, and you follow it up. Let's show a picture so you can see here's the area of cellulitis. They mark it off so they can monitor whether it's getting worse or getting better with the treatment. And like I said, you see streaking where it runs up the lymphatic ducts. Common cause is Staphylococcus aureus staph, and one of the ways to treat it is through systemic antibiotics, and which are going to hopefully get rid of the infection, and it's going to clear the redness. The next up is a boil or furuncle. These begin as a red painful nodule, and they develop into a painful mass or abscess where it's walled off. And they often have a purulent exudate, which is the pus, and it is drained. Often the common bacteria is Staphylococcus aureus, and it usually begins in a hair follicle and then spreads to the surrounding dermis. We can have some auto-inoculation occurring, where we spread by trying to mash or trying to break it ourselves, we can spread the bacteria into the surrounding tissues, such as cellulitis, or spread internally. We treat this with systemic antibiotics. Let's see if we got a picture. We can see here's our furuncle. It hasn't really came to a head yet, but it's that large papule. Okay, no, painful nodule, I should say. Impetigo is another bacterial infection that can be caused by Staphylococcus aureus in children and infants, and then sometimes in older children we see it as a group A streptococci, beta hemolytic streptococci. Strep is in a chain. If you go back to infection, Staphylococcus is in clumps, in circles. All right. Then we see they begin as small vesicles which enlarge rapidly. They rupture, the vesicles rupture, and then they end up having brown crusty masses on above it. It can usually spread through physical contact with fomites. Fomites are inanimate objects that spread infections. We can use topical antibiotics, and then if it's severe, we can use systemic antibiotics. Now let's look at our picture. Here we can see impetigo. You can see here where it's crossing over. And you can see the vesicles. Okay. Next up, we have acute necrotizing fasciitis. This is a terrible one. This is where the flesh-eating disease, we call it, it's severe inflammation with tissue death, necrosis, with gangrene, which then the bacteria are actually growing in the gangrene, and then it's going to spread. So flesh-eating disease, it's very painful and rapidly increases in time. It starts with some kind of bacterial invasion with from some kind of small trauma, so a small nick or cut just randomly. She is really severely inflamed and infected, and it spreads. Some of the things, and it usually has a mix of bacteria in there. It's just not one type, and it can really cause systemic toxicity. If it spreads to the blood through the whole body, and cause fever, tachycardia, which is increased heart rate, and hypotension, which is lead to shock. For treatment of this, they usually have to be very aggressive with the antimicrobial treatment, replace the fluids, excise the tissue, so that means remove the tissue. They're going to do it several times, and try to stay ahead of it, cut and remove, so it doesn't continue to spread. They may have to do amputation, remove the whole area, and hyperbaric chambers, which is where they have high pressure chambers with high oxygen levels, have shown to help. So, but this is, like I said, that flesh-eating disease, acute necrotizing fasciitis. If you hear of somebody having flesh-eating disease, that's what they're talking about. Let's see if we see a picture. And so you can see the gangrene, and it's spreading rapidly, and you see the margins. So they're going to have to excise all that out. It says a late diagnosis here. Next up, leprosy. You can see right here, this is a person that has leprosy. We call this Hansen's disease. What's interesting about this is that it is totally curable, and it's a very slow-growing disorder. And it generally affects the skin, mucous membranes, and peripheral nerves. And then since the peripheral nerves are damaged, that can lead to even more damage of the tissue because you can't feel, and you bump yourself, and you don't have great control. And that can eventually lead to a loss of limbs. It's caused by the bacteria Mycobacterium lepra, and it actually takes sustained contact, actually living with somebody and being around them a whole lot. It's not very contagious. To be honest, even though we had all these leprosy colonies, it really wasn't that contagious and it's slow growing. The effect of it is really worse is loss of limbs and extremities. It can be treated with antibiotics, rehabilitation, and education, really letting people know that it is a curable disease. Then we're moving into the viral infections. Okay, the first one is Herpes Simplex, and there's a few different types. The first one we're going to talk about is in this section is the Herpes Simplex 1 virus, and this is a virus that can remain latent in the trigeminal nerve in the face. This is the oral herpes, and it reactivates. So latent means it's going to be dormant, and then when the immune system goes down or for other reasons, stress and things like that, it reactivates and it forms these vesicles with crust over them, and it can be very painful. Okay, some of the risk and effects is it can actually spread to the eye if you touch that vesicle and spread it to the eye, called keratitis, where we have infection of the cornea and can cause ulceration. Acyclovir is a antiviral that has been known to help treat it when it's in the acute stage and actually showing symptoms. And usually if you do it before, when you can feel it start coming up, that's when you should treat. That's the very image. So here we go. We can see our vesicle here, and it will crust over. Verrucae or warts are caused by hemopapillomaviruses. All warts are caused by hemopapillomaviruses. One example of them are Plantar's warts. They puriform, raised papule, but they have sometimes develop a rough surface with a white or tan in color in the middle. You sometimes hear people say they like to see the seed in the wart. Treatment includes freezing with nitrogen, or topical medications where it burns out that damaged papule. Now let's see. Here we go. Here's one. Here's another one. Looks like that one over there may have been treated. Next up is Tinea Pettis, which is a fungal infection. So we're moving on to the fungal infections or mycoses. There's several different types. There Tinea capitis, which is a fungal infection of the head, Tinea corpus, which is a fungal infection of the body, and Tinea pedis, which is athlete's foot, fungal infection of the foot. Tinea capitis is where we have a circular patch of fungal infection on the scalp. Often has erythema, which is the redness and scaling. It's caused by fungus Microsporum canis or Trichophyton tonsuranus. Okay, these are treated typically with oral antifungals. Ringworm, Tinea corpus, is where it forms a ring, erythematous ring of vesicles or papules, and can be itchy or burn. It usually occurs on non-hairy parts of the body, and treated with topical antifungals. Tinea pedis or athlete's foot, as the skin between the toes becomes inflamed, macerated with painful or pruritic fissures, and may have a foul odor. Again, this is Trichophyton mentagrophytes or Trichophyta rubium, and these are treated with topical antifungals as well. So these two are treated with topical antifungals, and then Tinea capitis is usually treated with oral antifungals. Here we can see Tinea pedis. This is Tinea corpus, Tinea capitis, and Tinea pedis. Okay, so 3 fungal infections. We don't have a whole lot of fungal infections in normal healthy adults. Next up is a infection from scabies, which is a parasite. They're small Sarcophagus scabia, and these are little mites that bury through the epidermis and lay eggs over several weeks, and then they make these burrows, which is where they're burrowing through, these tiny little brown burrow lines, and they have small vesicles, and then the eggs and larvae emerge from them, and then they burrow for nutrients, and it can cause inflammation and pruritus, itchiness, and when they scratch, it can cause infection. That's the secondary thing. It's spread by close contact, and then you can topical treatment with lindane. So that's scabies. Let's look at the picture. So it's a tiny little mite, lays eggs, and then the larvae burrow through the skin, causing the little lines. Then next up, we have pediculosis, which is lice. And depending on where it's located, that's what kind of lice it is. We can diagnose it when we see the nits or the eggs in the hair. It causes very highly pruritic, which is very itchy on macules and papules. And then we get excoriations and wounds from scratching. These parasites will feed off the human blood and lay eggs to cement to the hair shaft. So to remove it, we can use topical pyrimethamine. This is insect killer. Use a fine-tooth comb to remove the nits and clean clothes and linen. So this is lice, pediculosis. Okay, let's see. Now we can see. Here we go. We see the nits here. Those are the eggs, and they feed off the blood. This is a head lice, and there's a head lice, a body mice, and then a genital lice. They're a little adapted to their general areas. Then lastly, we go into the skin tumors. We have the keratoses, which are benign lesions, and they're broken down into two categories: seborrheic keratoses, which are, and the actinic keratoses. The seborrheic are the proliferation of the basal cells. These are benign. They're oval elevation that may be smooth or rough, and is dark in color, usually on the upper trunk or face. Okay, and then we have the Satanic Keratosis, which are pigmented, slightly scaly patches, and these are usually caused by UV light with a fair-skinned individual. These need to be watched because they can develop into squamous cell carcinomas. And then that leads us to the squamous cell carcinomas, which are painless malignant tumors of the epidermis. They're usually scaly, slightly elevated. They have a reddish lesion with an irregular border. That's something that we can look at. And ulceration in the center, which is that open wound of erosion. Sun exposure is the main cause. Also smoking on the lips and the base of the tongue. And then we can have scar tissue can also cause it. These rarely metastasize, and they have good prognosis when they are removed in time. These squamous cell carcinomas. So let's look. So here's a squamous cell carcinoma. Irregular border. You can see this ulceration in the middle, scaly red. And then we go to the malignant melanoma, which is going to be where we have cancer cells, usually with the melanocytes cells. They are multicolor lesions with an irregular border, and they grow rapidly. The cancer develops from the melanocytes. There are some genetic factors that are involved, and more sunlight, radiation, and hormonal levels can affect this and increase the risk. These metastasize very quickly, and if they aren't removed, they can be deadly. Removed quickly, and you need to have additional radiation and chemotherapy to sort of stop the spread of these malignant melanomas. These are very dangerous, and one of the things that we see is this is the one that we want to keep a check on. So we can see here irregular border, large, and then you can see this dark multicolors. And so we should always look at ABCs, which is the appearance, the border, the color, and the diameter. And this nevus is a mole. So when we have a mole that's suspect, it's going to have changes in this, and we need to consult with a dermatologist or a doctor as soon as possible. And the last one is called Posses Sarcoma, and you can see these purplish lesions over the body. These are where we're usually dealing with the immune suppressed, either AIDS patients or those with severe immunodepression, such as and these are non-painful. These large peripheral rashes, macules that are non-painful, non-itchy. They actually progress to form these irregular plaque shapes, and it happens from malignant cells that come from the blood vessels, the endothelium of the blood vessels, which is the cells that line the blood vessels. Have to be treated with radiation, chemotherapy, surgery, and biological therapy. And so that's our last one. All right, so let's see. That's it. So let's stop right here.